All right. Okay. Good afternoon-ish. Good morning. Thanks for everybody who is here today and spending our lunch break with us. Today presentations will be not so much brief. I have some slides, but it's definitely, I would like it to be interactive. So you're more than welcome to go ahead and share your thoughts on the chat, and we can answer some questions at the end. Okay, so my name is Cynthia Gneco. I'm originally, just to give you a little bit of background, I'm originally from the Dominican Republic, and I came to the United States a few years ago. I trained in the Northeast, mainly in Philadelphia, Jersey, and for the last almost 3 years, I've been in San Antonio. I'm board certified in internal medicine and also in geriatrics, and I'm here located at the Holy Cross Clinic alongside with my colleague, Dr. Dominguez. Okay, so today we're going to talk about a little bit of depression, which is a big topic, but nonetheless pretty relevant of the ambience that we've been living in the last few months, right? How do I pass this? Okay. All right, so depression is one of those things that unfortunately has to carry and still carrying a lot of pragmatism and a lot of kind of a voodoo topic, especially amongst our population, a geriatric population, and the surrounding Latino population that we have here in San Antonio. Most of the time is underdiagnosed. In some series and some studies, they report that 40 to 70% of the patients that come in the clinic do have some degree of level of mental health and depression and anxiety that is being underdiagnosed. Mainly because of the reason is that we don't screen those patients as often, and other reason is that they don't disclose those symptoms. So it's really hard to diagnose. The definition, just to give you the correct verbatim here, is in a spectrum of mood disorders characterized for substance disturbance. It engloves everything: emotional, cognitive, behavioral, somatic regulation, that is associated with a significant functional impairment or reduction of the capacity of feeling pleasure and enjoyment. So you may read these and say, well, that's me every day. But we're gonna go through some of the specific symptoms and characteristics that define this disorder. So who has them? A lot of us, unfortunately. Over 14 million American adults every given year. Technically every, 7 out of 10 have depression at some time in their lives. The teens usually express that as well. In some series, 20, 30%. I was reading yesterday, some series in 55% in the Netherlands, which is very high. If untreated, can lead to suicidal attempts, more successfully, unfortunately, in women than men. What other notice? Sometimes these patients comes in, especially the geriatrics, they come in with the family members or either co-workers express some symptoms that they're seeing very commonly. Example of this is talking very badly at work, abusing either alcohol or drugs, picking up fights, being irritable, having trouble at work, not committing to the scheduling, talking subtly about separation, divorce, either eating disorders, eating too much, eating too little, sleeping too much or too little, and having unusual and characteristic features on their behavior. These people become erratic or either apathic, or either they're just shut down into themselves. It's important to mention that depression and anxiety, they do have overlapping symptoms, and sometimes it's not easily separated. They can act, they're not mutually inclusive. That's what I kind of mean with that. With anxiety, we have some symptoms of dread, fear, and worry that it's really ongoing and is every day up to certain degrees. Depression is deeper than that. Who has anxiety? A lot of us have it. Over 4 million adults in the United States suffer some kind of anxiety disorders. They come from prolonged bereavement to generalized anxiety disorder to dysthymic syndrome So there are different definitions and characteristics of what anxiety is. Now, in order for us to diagnose clinically and to measure the guidelines, there are some paramount symptoms that most exist in order for us to diagnose the process. You have to have one at least of the gateway of the most, what we call the principal symptoms is either depressed mood or loss of interest and pleasure. Other symptoms that can appear, as I mentioned before, is either change in the appetite, insomnia, psychomotor agitation, loss of energy, feelings worthless or guilt, difficulty concentrating, difficulty making decisions, recurring thoughts of suicide, harming yourself or harming others. In med school, they teach us that kind of nomenclature. I'm pretty sure in other fields they do have for us to remember is the CGIC caps. And it's basically all the symptoms that I mentioned before, as you can see. Common sign, unfortunately, and this started, I don't know if you remember when the news started coming about, when the COVID hit the United States, that 20 to 30% of the alcohol sales have increased. And that is not uncommon to see in depression. You know, these patients tend to linger on those habits that they had in the past, but now it's sort of like a coping mechanism. And abusing alcohol and drugs is something very common that we see as well. Up to 9 to 15% of full-time workers, which is a lot of people. It's around 13 million people have problems with alcohol consumption. And we see that from the youngest onto the geriatric population as well. Now, there are some intrinsic risk factors as well that could precipitate or could put a person into the verge of having a depression flare-up or episode. Some of them is the same alcohol addictions, hearing or vision impairment when you are not able to engage with your environment, you tend to enclose yourself. And that's very common in the elderly in situations where they live in nursing homes, assisted living, or either at home, but they live by themselves and they don't have a caregiver in which they can engage a conversation. History of attempted suicide in the past or history of psychiatric hospitalization in the past is something that also very common is a risk factors. Family history, there's a strong correlation, especially in patients with bipolar, first generation, daughter, mother, brother, son. New stress, the birth of a child, the loss of a job, the loss of a relationship, conflict at work. All those things can precipitate. Now, initially, within the first couple of weeks, it's not considered to be depression. You have to have at least 3 months of ongoing symptoms in order for us to diagnose that. But there is something called adjustment disorders, which is from time 0 to time 3 months, that we can't see those changes in which the activities of daily living, whether it's work, whether it's handling the household, the kids and the husband, becomes really cumbersome. It becomes really difficult. So the diagnosis in the elderly patient is difficult because, and I say a lot of elderly because I'm a geriatrician, that's what my focus is, but we do have a lot of young population here that comes to still work, they still function in the society. Some people would say, well, you know, my grandma, she stays at home, she's really quiet, she really doesn't talk that much, and she hasn't been eating that well lately. Well, guess what? She might be depressed because it's not something they will say, hey, I think I'm depressed. They don't tell you right away. You see some faint symptoms. So, for instance, they no longer want to go outside and do the garden like they used to. They don't want to play with the grandkids. They used to love cookies and now they don't like cookies and they just like to just drink water and soup. And it's not something that they are used to. It's a change in behavior, and that's really faint, but that's a sign. Most often than not, they report guilt because they feel guilty on saying those things to their family members because they don't want to become a burden when those things comes in. And also, depression is 20 years ago used to be called pseudo dementia. Why is that? Because when you're not engaged in your environment, when you're not paying attention to things around you, what happens? You don't learn things new. Remember when we were kids that between the ages of 2 and 10, we go to school and we are focused on that screen board, focused on what the teacher has to say. And those things kind of stick to our brain is because we are paying attention and there is some kind of focus. Whereas when you are depressed, that focus is lost. Hence, the hypothalamus, that part of the brain that creates new memories, is basically shut down. So it might seem as though you're losing your mind, like you are forgetting things. So I have dementia. No, basically you're depressed. Something that I read, I don't remember where, but it kind of stick to me, is this phrase: it's not what happens to us what makes us depressed, but how we respond to painful emotions. Things will happen in our lives where, whether we like it or not, whether we have control or not, but how we respond to them is what makes us succeed. So it's a matter of choices. And the most important choice that most therapists, when they start working with patients with depression, is the key word of willingness. Will you be willing to work on this and overcome it? Will you have the structure or the will to make changes to make it better, or change your shatter inside of you? And this is an important, if you take anything out of this talk, this is an important sentence here. Things will happen, but how we respond, that's the key. And that is called basically reframing. The reframing and negative thoughts can help us turn them into positive possibilities and reduce the stress and an improved mood. And I can give you some examples. Yes, we are in the middle of a pandemic right now, and we can't control it, right? We can only control our household using the mask, social distances, and all those things, but we can't control what other people do. So how do we not stop, but shift those negative thoughts into something positive? Like, okay, well, I'm at home. I can go to the restaurants or to the park as I used to with my kids and playing with the other kids, or sharing those things as I used to. Well, I think this will be the time for us as a family to share more time together, to maybe do activities together, go and painting, go hike, go to the beach and have that time within each other, or just simply sitting down and doing the homework. That's quality time. And that's something that, during this time we have more time to do because we are restricted to do other things. Reframing is an exercise, as everything when it comes in not only organic medicine, when we have a diagnosis and we have to work on that, but also in mental health. It's something that we have to practice every day, little by little. The next 3 slides is just to mention. I'm not going to go through most specific with what the medications that we use for depression are, but just know that they are drugs that we use in case that we need it. In the GERD population, and mostly in the 40s, 60s, it's been known that behavioral therapy plus an antidepressant will be the best approach. There is not a magic one pill, do it all antidepressant. Usually we use combination of, and it's a trial and error. These are some of the families, the TCAs, the SSRIs, and the atypical ones, which are in the bottom. Every one of them has a different characteristic as to when and why we use it. There's an algorithm that we go through basically, and I can give you some examples. For instance, somebody that has depression and has a lot of spinal stenosis or back pain, and his heart is fine, and that particular person is not having problems sleeping, well, I will choose duloxetine because that will be the best one. And someone that He's really skinny and he's having issues with gaining weight, but guess what? Has depression and can't sleep. I will probably use mirtazapine. So each and every one of them has a function, has a role, but each and every one of them has side effects as well. And that's something that we explain at the time when we prescribe those medications. And this is just explaining, for instance, the TCA, which are the older ones that we have in our arsenal to use. Because they're old, they have a lot more side effects than the new ones, like dry mouth, constipation, and whatnot. But that's something that we discussed with the patients. Those are the SSRI. Those are the most well used, the less side effects, but they do have side effects. The takeaway from these slides is this. Most of the time, the first pill that we prescribe will not work. Only 40% of the times they work. So we try and error. We increase the dose. We change from the TCA to the SSRIs, or we either add Abilify to add that to that, or we try therapy for a time. We give a holiday of one medication, then we add. So there is not like a magic algorithm that you have to follow and this will work. We need to try. There are some things that are not here, like having brain stimulation or either electro ECT or electrocuted therapy that we often use. It sounds really barbaric, but there are some cases that some patients require that, especially the elderly that have a lot of side effects, have a lot of heart problems or whatnot, and they cannot tolerate these meds. The no pharmacological treatment is the first approach that we take. Whether it's exercise, occupational medicine, but I will explain those things more in the following, which is the good habits. And I think we're going in time. So the first slide was, if there is a problem, how would you respond to it? How being willing to work on the problem. The second thing that I want you to remember is this one, the good habits. What you should do to try to cope during this time of trouble. You know, we're in the neuron epidemic. There's things that we can't control. First of all, you choose the tone of your day. How would you like to approach your day? And it sounds silly, but it does work. I can tell you, my phone doesn't sleep with me in the same room. That phone is in the other room. My alarm is on the other side. Try not to see news during the morning. Try not to, the first thing that you see, social media, turn out your phone, because that will play out your day. That will set up your day. So how would you get good habits in terms of choosing the tone of your day? Well, you express gratitude, whether you're religious or not. Okay, you close your eyes, thank you God, or thank you Buddha, or thank you whoever your faith is for this day and for me to be alive. Meditate, reading a little bit, whether it's a chapter, whether it's a sentence, or having some kind of shattering your wall, a post-it, something that is positive. Don't start your day with the CNN news and hearing everything bad that had happened the day before. That will happen in the future, because that will set up your day. Sleep, get enough sleep, listen to your body. And that goes without saying, you know, you work 12, 18 hours a day. I don't know your schedule, but at least get your brain to rest and to reset. And your body will speak to it. Do an experiment for the next week. Try to sleep 6 to 8 hours of full sleep, not, you know, going back and forth and try to watch a movie or disrupt or the kids. I know it's hard when you have kids to do that, but get enough sleep is being proven. There's a lot of studies that is being proven to improve the quality of life. These sound silly too. If you work from home, guess what? Get a shower and get dressed. I know that we do a lot of Zoom meetings, and I know that we also that not just dress from the bottom up, but getting dressed, putting a little lipstick, putting perfume, and get your setup like, hey, this is my day. That will help out with the set mind of, okay, I'm gonna head out and I'm gonna conquer this day. Nutrition. eat well. I had a patient that once told me, I asked her, she was 92. I was like, how do you keep yourself so young? And she said, well, I drink my water, I take my vitamins, and I mind my business. And I thought to myself, that is hilariously funny and true. Like, it's really true, you know, and she looks marvelous. And she takes no pills and everything. And she was so healthy. So kudos to her. So, you know, eat well. When you change your diet, you will see marvelous things, not only with your weight, but the way that you feel. The same thing goes to exercise. If you Google exercise and depression, there's a ton of data out there, and it goes with what exercise does to your body. It increases endorphins, it increases the cardiovascular pool that you have throughout the day. Some study says that it's better in the morning, but for some people it's impossible because they have 4 kids and have taken to school. Maybe do it in the afternoon. Get outside and get some nature time. Go and smell the roses. It sounds ridiculous, but it does work. Do some gardening, do some passion projects, whether it is, I don't know. I had a patient that she collects stickers, and that's her passion, and that makes her happy. Do something different and pick a hobby. Make a relaxation a priority, whether it's meditation, whether it's going to church, whether it's just watching a calm documentary about dolphins. I don't know, whatever makes you happy. Also express gratitude. We forget the fact that, for instance, I don't know who is in the other side of the screen, but it's because we have a job, it's because we're alive and we're healthy enough to do this. So that's enough motive to be grateful of what we have today. As I mentioned, schedule a hobby, take a Sabbath off. It sounds really kosher, but it's true. One day at a week, disconnect, do whatever you have to do to rest, and have some kind of social interaction. When the word social distance started coming around, I was a little worried that people will interpret it as just separating myself from the whole world, which is not. You can pick up the phone and call your grandma or your aunt or your uncle or your cousins, or, you know, FaceTime with your little ones that you haven't seen in a long time. That helps. We are social beings. We are not made to live alone. And I know that it's challenging at this time, but, you know, phones, computers, the technology is in there for us to do that. Or I've seen now in Facebook this trend that whenever there's a birthday, they come and do a parade with the cards. That is fabulous. That is so cute. And it does help and it does work. As I mentioned, practice gratefulness. You know, I recognize that I'm alive. I acknowledge the fact that a higher being allowed me to be alive, and appreciate the fact that I have health to work and share with my loved ones. There are some resources in San Antonio. These are only the 2 of them, but I know that the Cupid has some mental health, behavioral therapy resources, and it's usually in the back of the insurance card. There should be a number in which you can call. These are government, the first one is a government statewide mental health resource. The second one is the NAMI, which is ORG. It's basically a nonprofit organization. It's really good. They have talks all the time. They have a suicidal call, a number if you have a crisis, or if you need just somebody to listen to you. And I think that's about the sense of the talk. I didn't want to go into a very depth in terms of the medication and the technicality, but more so in simple things that we can do in a daily basis to try to improve our health. Thank you so much. Now, if you have any questions, Heather here, you want to go into the, sorry, you're good.